Hello everyone, welcome to this video. This is going to be a short review of the Glasgow Coma scale. Uh, there are multiple videos on the internet, but I think I'll help you understand not just theoretically but also practically how to assess Glasgow Coma scale. This is usually done to assess the level of consciousness of people who have undergone trauma, more specifically head injuries. I would also suggest you to read nice guidelines on assessment of Glasgow Coma scales, also nice guidelines on head injuries. I'd also suggest you to study the severity of head injury, the grading of severity of head injury according to the GCS. Now let us begin with the discussion of the Glasgow Coma scale. So there are three components of the Glasgow Coma scale. There are three things that we assess in a patient. We assess the patient's eye opening. We assess the patient's verbal response, and we assess the patient's motor response. All three components are abbreviated as E, V, and M. And while reporting Glasgow Coma scale, we report it as E, 4, V, 5, and M6. So I'll tell you what 4, 5, and 6 stand for. But what I want you to remember is when we report Glasgow Coma scale, the number that we choose should be the best possible number. Okay, so I'll tell you what that is. Let us start with eye opening. Now you can understand eye opening like this. Okay, so if the patient is there, and the patient is spontaneously opening their eyes, you give them a score of 4. If the patient is not spontaneously opening the eyes, but you go there, call their name, you try to talk to them, they open their eyes, look at you, and they talk to you. Once you stop talking to them, they'll go back and close their eyes. So if that is happening, if they are opening their eyes in response to speech, you give them a score of 3. You call the patient, but the patient does not respond. Now if the patient does not respond, you can apply pain stimulus. But where do you apply that pain stimulus? On the axial regions. Okay, you'll not be applying pain stimulus on the peripheries. Why? Because I'll tell you when I discuss the motor component. But you apply pain stimulus maybe on the axial region. That means you'll maybe in the central regions, maybe in the face, in the supraorbital ridge. So if the patient is responding to pain, opening the eyes to pain, then you give them a score of 2. Now despite applying painful stimulus to this patient, the patient is not opening his or her eyes, then you will, if there is no response, then you'll give them a score of 1. Okay, as you can see, the minimum score in eye opening is 1 and the maximum score in eye opening is 4. Let us proceed to the next component, the verbal response. Again, EVM. The second thing is verbal response. So verbal response means the ability of a person to speak. Okay, so the speech of the patient. If the patient is speaking normally, that means the patient is oriented to time, place, and person. You go and ask them, do you know what time of the day is this? Do you know what month this is? Do you know where you are? Do you know who I am? And the patient is able to answer all of your questions satisfactorily, then you give them a score of 5. So if the patient is oriented to time, place, and person, you give them a score of 5. If they are confused, they are speaking in sentences but they are confused, then you give them a score of 4. If they are not speaking in sentences but they are using inappropriate words, for example, a patient in our setting, in a Nepalese setting, would maybe say aya dukyo, aya dukyo, aya dukyo, maybe continuously be saying aya dukyo, aya, or else the patient might be saying malai bachao, something like that. Okay, the patient is just speaking words, the patient is just blabbering some inappropriate words. That would account for a score of 3. The fourth, if the patient is not even speaking in words, but the patient is producing incomprehensible sounds, incomprehensible sounds, you would give them a score of 2. So let's say that a person is coming to you, talking to you, he or she is telling you, Dr. Saab, this has happened to me. I was there, I fell, I met an accident, so I have a pain in my head. So the patient is definitely oriented to time, place and person, so that gives you a score of 5. Let's say the patient starts telling you, Mokansu, I don't know where I am, please help me, and things like that. Patient is quite confused, and patient is speaking in sentences, but patient is confused. You give them a score of 4. The patient says like continuously blabbering a bunch of words, but these are inappropriate words. The patient does not speak in complete sentences. The patient does not respond to your questions. You ask them, do you know what time it is? The patient will respond with ayadukyo. Okay, so that is known as inappropriate words, and you give a score of 3. If the patient even does not say ayadukyo, the patient says the patient is moaning, the patient is producing some incomprehensible sounds, you do not understand what the patient is actually trying to say, you only hear some incomprehensible sounds, you give a score of 2. If there is no response at all, you give a score of 1 and not 0. Again, in verbal response, the minimum score is 1 and the maximum score is 5. Therefore, E4 and V5. Now let's talk about motor response. If the person obeys your command, you ask the patient to raise the hand, the patient raises their hand. If you ask the patient to flex the knee, the patient flexes their knee. If the person obeys command, you give them a score of 6. If the patient does not obey command, you apply painful stimulus. Okay, so you have applied painful stimulus where? Not in the peripheries, but in the center. Okay, so you are applying painful stimulus in the supraorbital ridge, for example. So you have applied as painful stimulus, the patient localizes to pain. What does that mean? What does that mean? That means you are pricking on the patient's head, right? So the patient would try to flex their hands, and they will try to bring the hands close to the source of stimulus so that they can push it away, right? That is exactly what we do. If something is hurting us, we move towards that object and we try to remove it. So if the patient is not obeying command, but the patient localizes to pain, you are providing a painful stimulus and the patient is trying to push it away. Okay, so patient brings their hand up and tries to push it away. That is known as localizing to pain. You give the patient a score of 5. Let's say the patient has a flexion withdrawal to pain. Now this is very important to understand. Okay, so what does flexion withdrawal to pain basically mean? You give a score of 4. So what does flexion withdrawal to pain means? Basically, if you are providing a painful stimulus and the patient is flexing their limbs or bringing their limbs towards that painful stimulus and trying to push it away, that is known as localizing to pain. They are localizing to the painful stimulus. They are localizing to the site of the painful stimulus. But if they cannot do that, they will try to go away from the pain. Okay, they will try to go away from the pain, and they'll do that by flexion. They'll try to go away from the painful stimulus, and they do that by flexion, and that is known as flexion withdrawal. They are trying to withdraw away from the pain. that is known as flexion withdrawal to pain. Okay, you give a score of 4. Abnormal flexion is known as, now some people, sorry, you give a score of 3. Abnormal flexion, some people say that they are trying to localize to the pain, but they cannot. But this actually is so this particular thing is actually, we mean to say that the patient goes into decorticate posturing. Okay, so the person will go into decorticate posturing. Abnormal extension, when you this person is in a state of abnormal extension, this is known as decerebrate posturing. Now if you do not know what a decorticate or a decerebrate posture is, I would highly suggest you to refer to the videos on decorticate and decerebrate posturing. Basically, in decorticate posturing, you would have your hands, the upper limbs on flexion and the lower limbs on extension. In a decerebrate posturing, everything would be on extension. Okay, so therefore it's known as an abnormal extension and an abnormal flexion. It's not a flexion that a normal person is doing to withdraw from the pain or to localize to the pain or to push the painful stimulus away. It's not that. The person is in an abnormally flexed position. It's not a functional, it's not a let's say productive movement. Okay, so the person is in a state of abnormal flexion, you give a score of 3. If the person is in a state of abnormal extension, you give a score of 2. Finally, if there is no response at all, you give a score of 1. So what is the minimum amount of score that a person can secure in the according to the Glasgow Coma scale? 1 plus 1 plus 1, that is 3. So the minimum score is 3. And what is the maximum score? E4 V5 M6. 4 plus 5 is 6, 5 plus 6 is 15. So the maximum score that a person can get in the Glasgow Coma scale is 15. Just as a added pearl, whenever the person has a Glasgow Coma scale of less than 8, then this person has to be intubated. I hope you've understood the Glasgow Coma scale. Please note that there are modifications to the Glasgow Coma scale according to the age group of the patients, and there are several other modifications, but this is something that you need to know in your general clinical emergency practice. Thank you for watching the video. Have a great day.